The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our December 18 Safe and Calm webinar. This is Deanna Mitchell from LeadingAge Michigan. As we approach the height of the holiday season, we would like to take a moment and wish all of our members and their staff a wonderful holiday. We know that it's a little hard during this difficult time, but we want to recognize the staff who throughout this pandemic has provided ongoing care, dedication, and service to our seniors. So thank you to all of our members for that. Today, we don't have a lot of new content, but we want to provide some brief updates about a few topics that are evolving and important. We're going to go through the holiday calendar, remind everyone what our plans are for the next couple weeks. Dalton will provide some updates on bills that have gotten some traction, and those bills are important to our members. And these unbelievably sort of have moved through during the lame duck session. And we will briefly touch on vaccine updates and some discussion of some MIOSHA issues. Again, we want to remind all of our members that we do have 2 webinars scheduled between now and the end of the year, at this point at least. Next Wednesday, we have 2 speakers scheduled who will be covering important issues. The first is Eliza Lintemuth, who will be covering issues around mandating vaccines for staff, and Dr. Dana Prince, who will be sharing the St. Anne experience as a care and recovery center. And all of that will be on December 23rd. On the 30th, we do have a webinar on the books, just in case there are some pertinent updates that might be important. We do ask that you watch your emails, since that's only tentatively scheduled at this time and will be dependent on what's happening. Considering, though, that the vaccine situation is evolving, I would plan to attend on the 30th if you can. We'll now turn the presentation over to Dalton, our Director for Public Policy.
Good morning, everyone. As Deanna alluded to, it has certainly been a very interesting last couple of, well, I'll say 48 hours-ish, probably 36 hours. A lot of things have happened, and a lot of things have changed even since our last call. So to start off, you may have heard that there is a budget supplemental in the works. The governor's been calling for various kinds of funding to be distributed out to help support the COVID-19 efforts of the state and support small businesses affected by the virus. After those calls, the governor in particular asked for $100 million program from state funds to be developed and another $200 million supplemental. Instead, the legislature and her are working on a roughly $300 million supplemental package that is going to be negotiated today. Today is the last day of scheduled session, so if it's not done today, outside of them adding another session day, which they don't plan to do right now, today is the day for the negotiations to happen. Very few details are known. The budget for this budget supplemental is only being passed along leadership and the governor, and they're currently negotiating on it, and they're being very intentionally tight-lipped about the information in there. We do know that these will be all state funds, and they may be reimbursed with federal funds depending on what the next federal COVID relief package looks like. But as for the details we know that the funds will primarily focus on families, small businesses, and healthcare workers, and also the unemployed. It's rumored to be slightly less than $300 million. We expect to see an extension of the $2 an hour wage pass-through for direct care workers and SNFs and other settings. And we also have heard from policymakers that there may be other funds to help places retain and hire new staff, but the details about that are still unknown at this time. We don't know if it will be even in there, as we don't know how their negotiations are going right now, because they started about 45 minutes ago or so. So we'll see where this ends up at the end of the day today, and we'll have a report out on our next meeting. Late last week, we did have this out in one of our COVID letters. You may have, or LMI newsletters that focus on COVID. It was kind of on the bottom in an advocacy section. But I did not share the information on the call. The medication aid bill, it has been sent to the governor for her signature. This bill was passed along party lines, and our feelers out to the governor's office have came back empty. She hasn't responded with what she's thinking on the legislation, what she's going to do there. We have supported the legislation throughout the process. We'll continue to support the legislation to try to get this done. We know it's been many, many years that this has been in the works. Just for a quick recap of what this bill does, it allows for the use of medication aids and SNFs. It provides the licensure rules and the training models for these aids, and these aids would then be allowed to pass regular scheduled medication underneath the supervision of an RN, with exceptions for controlled substances, injectable medications, as needed medications, and the initial dose of a medication. So one of the things that's happened, it happened yesterday, the House decided to change the rules on everyone and started discharging bills from committee. What this means is that the bills are moved directly out of committee and onto the floor. Many of those bills onto the floor for a vote. Many of those bills skipped multiple committees throughout the process, and the House is just moving a number of different bills through this kind of a process, which is not done. It's not done very often, where they decide to skip committee, and there was no indications from everyone I've talked to that anything like this was going to happen. But clearly, some of the legislators who are going to be leaving the chamber had some bills that leaving the chamber because they're termed out, really wanted to get some bills across the finish line, or try to get some bills across the finish line. One of those bills was the electronic monitoring bill. So that bill is discharged from House Health and Human Services Committee, skipping the Ways and Means Committee, and moved to the floor for a vote within, I want to say 7 hours or something like that. It was 7 or 8 hours. I don't remember exactly. We have reached out to many people, letting them know that we don't think it's the best time to pass another bill that would implement a kind of a new program into a skilled nursing facility during a pandemic. But thankfully, the bill wouldn't take effect until June 1st. If it is signed, it's not law right now. The bill still needs to be concurred by the Senate, but we do expect that to happen today. It was passed largely along party lines, with only 6 Democratic lawmakers joining the Republicans to pass the bill. The governor, once again, has remained silent on the bill and on the legislation. She does, however, now have the opportunity to pocket veto a bill. A pocket veto is where she can essentially veto a bill by not taking action on it, because the time limits for this current legislation will be up on the 1st. So she can just sit there and wait it out without having to make any kind of a comment on it. We do know, at least in the past, in past legislatures and with a different governor, her party has tended to not be on the side of this kind of legislation. So we'll see. We are continuing to follow it throughout the process, and we'll continue to reach out to see if this bill does become law, but right now it is not. And we'll be waiting on her desk for signature, I think, by the end of session today. In more positive news, another bill that came out was the healthcare immunity bill. That bill was passed late last night along party lines and is on the way to the governor's desk now. This bill is a little different than the past ones. In the past, it was for a certain time period. This one covers different time periods, but also adds CRCs to the immunity language. So if you have applied to become a CRC and accepted as a CRC, you will then fall within this immunity coverage. This immunity would cover the periods of March 28th to July 14th and October 29th to February 14th, 2021. So this bill is really designed to kind of fill in the holes that the first bill didn't have. We know from this one that the governor is not a fan of this kind of legislation. The last time a bill like this was passed, it was due to legislative compromise over a different supplemental bill for COVID. It was kind of a, I'll sign this if you pass this kind of a thing. We also know that the national discourse around legal immunity, especially along party lines, has started to heat up. And we know the governor is pretty active on the national stage. She was in the consideration for a vice presidential run just in the last election. So we know that she is closely following this kind of national discourse. So we'll continue to support this as it moves through, but we know the chances it gets signed are pretty slim from our perspective right now, but you never know. So just some important dates. I did have an update. As of the 16th, the third round of provider relief funds have started to be released for SNF providers. You should expect to see those come through within the next month or so. The HHS did give an estimated end date for these distributions of the end of January, so the 31st of January. So you will see some funds come in anytime between the 16th and the 31st.
All right. Thank you very much, Dalton. Before we get into any questions, each year LeadingAge Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. We do have one question, but I don't think that it pertains to anything you went over, so I will just hold it until the next time we have questions. So we are good to move on.
Okay, well, thank you, Blake and Dalton. Before we move on to our discussion about vaccines, we do want to let everyone know that we received a call from Kate Massey just minutes before the webinar. Kate Massey, in case you're not aware, is the head of Medicaid, the Medical Services Administration for the Department of Health and Human Services. She reports to Dr. Gordon, and she has been, the primary driver for the MDHHS response to the pandemic. At any rate, apparently the state has received a batch of monoclonal antibody treatments. If you're not familiar with that, these antibodies are provided to persons who are having symptoms from the COVID virus. It is an intravenous application. And with that, she would very much like to meet with the medical directors of our facilities next week. Right now, this session is tentatively scheduled for Monday around noon. We have not received confirmation about that, but apparently some of these treatments might be available to long-term care and for sure hospitals. So we encourage our members to connect with their medical director and tentatively schedule themselves for this discussion, and we will be sending out more details about that as they become available. So briefly, I have just included our routine 2 slides this morning about the state of COVID in Michigan. You can pretty much see that there's a downward caseload trend, and that continues pretty consistently, so that's very, very positive. Hopefully we will continue to see this as we move through the holiday season. So this is good news. These trends are continuing. For deaths, however, They have still not caught up to that trend, but at least they appear to have stabilized a bit and they have stopped moving upward. Hopefully, we will start to see some declines here in response to the decreasing caseload in the next several weeks, and we certainly hope that the caseload continues to be on the decline even through the holiday. So moving to our section on updates and resources, we are going to, of course, start with what's happening with vaccines. Remember, we ask everyone to remember that the volume of information from so many parties is unbelievable about the vaccines. And so we're always trying to integrate and trying to figure out what's the most accurate and the most current information. So if you have information or some experience that would help us, we certainly hope you put some notes in our chat box, and we'll certainly review them with our members. So on Thursday, the department announced some news regarding vaccine distribution. Michigan has received, they received 84,000 doses initially, and a second distribution of about 60,000 doses was received on Wednesday. And this is all, of course, the Pfizer vaccine. These doses are anticipated to cover the hospital staff and the local health department needs. Those are the first priority immediate needs. And of course, they're being distributed only to agencies with ultra cold storage ability. It's anticipated that these first doses will cover the hospital needs and the immediate local health department needs, and then it's possible that some will start going to long-term care. However, as we'll see later, the Moderna vaccine is actually supposed to be the vaccine that is most going to be used for long-term care in Michigan. So we went through the vaccine priorities for Michigan on Wednesday, and they've not really changed. The state says that some of these priority levels will likely overlap. They did reiterate that they plan to start administration to nursing homes the week of 12/28. And they also stated that other long-term care facility type providers will start receiving vaccines during the first week in January. One thing we did hear from the state yesterday is that the CDC, now mind you, we did not hear this from the CDC, we heard this from the department in Michigan, but that the CDC redistributed some of the facility assignments because during sign-up, it was so unevenly distributed across the two pharmacy providers, they decided that they had to adjust that. So the state has announced several times to us that the CDC list is considered final and that facilities are expected to use the pharmacy that is identified on the list. Long-term care facilities, as I mentioned earlier, are generally going to be using the Moderna vaccine. That's expected to be finally approved and shipped in the next week or so. The Moderna vaccine, remember, has a slightly higher effectiveness rate than the Pfizer vaccine. So these vaccines will go to sites in shipments of 100. The Pfizer vaccines are going out in shipments of almost 1,000. But these are much smaller shipments, and the state anticipates that they're going to get about 173,000 tests starting next week. The state continued to focus on the fact that pretty much all the same rules are going to apply about testing, exposure, quarantines, etc. Changes are only going to occur in those requirements when the community transmission rates really significantly start to go down. And as we noted earlier, they are going down a little bit, but overall, the positivity rates in Michigan are still pretty high. LeadingAge in Washington has a lot of contacts with Omnicare. and they provided some information to us a couple days ago about pretty much the CVS partners that they're working with. And CVS is stating that if you signed up for CVS, but you have not heard from your pharmacy provider, you can send an email to the address that's listed right here on your slide. Although we've been contacting many regulatory groups, the state, the CDC, LeadingAge, etc., for a few members who have not been identified on the CDC list, there doesn't seem at this point much positive response from anyone about what to do. The state has directly told us probably 3 times that if you are not on that list, you have to reach out to your local health department. So on Wednesday, we talked about the scheduling of the 3 clinics and the potential impact of staff side effects. And the CDC guidance did state that facilities can work to stagger these because of the potential of losing staff to feeling ill. But we also heard from you that the pharmacies are pretty much not doing that. LeadingAge, in their discussions with Omnicare and the CDC, they state, and they continue to state, that technically it is an option to divide up your staff and have them immunized, not all on the first day. But Omnicare would obviously prefer to do that. We've not heard from Walgreens. So if you have concerns about how to do that, you can talk to your pharmacy provider and see what they tell you. And again, the CDC always states, although this is not a very helpful, perhaps, recommendation, that you can choose to have some of your staff vaccinated through the local health departments later if you want to stagger it more than across 1 or 2 possible visits from the pharmacy partner. We do hear from the CDC that there's no way that they're going to schedule more than 3 clinic visits. They're kind of overwhelmed with the whole idea because they feel they've scheduled 3 for over 70,000 providers across the states. We have heard differing stories about vaccinating others on the campus. LeadingAge, in their discussions again with CVS or Omnicare, they've stated that independent living is definitely not in the scope of the pharmacy partnership program, but the pharmacies can vaccinate staff that work between levels. So we're encouraging everyone, in order to get as many people vaccinated as we possibly can, that you work with your individual pharmacy provider to see what you can do here. Additionally, across the past several days, the CDC has issued more information pieces on the Pfizer vaccines. Remember that some of the long-term care facilities in Michigan may get Pfizer vaccines, but most are still going to get Moderna. But they have put out a ton of documents and support materials about the Pfizer vaccines. And they have provided a bit more information on some of the precautions and considerations when vaccinating in general. First, they suggest not to vaccinate within 14 days of any other vaccines that might be administered. And of course, this would be most relevant probably for influenza vaccinations. So you need to schedule these 14 days apart if someone's getting any other vaccinations. And the other thing they say is that anyone with a history of COVID infection can still be vaccinated. They also suggest that testing specifically to determine if someone has an acute or prior infection is not recommended before vaccinating. So in other words, if you don't know now if the person has been infected, they don't suggest that you test to find out. But if you know someone who has an active current infection, you should delay vaccination until they have gone through their recovery phase. In fact, that delay can be as long as the 90-day full recovery period, because those persons are generally considered to have some immunity for at least that amount of time. But you don't have to. It is suggested that at least you wait until they have completed their transmission-based quarantining isolation. Anyone who may have contracted the infection and has been treated with antibody therapy, and that's the antibody therapy we were talking about just moments ago, they should wait 90 days before receiving the vaccine. If a person has had a significant exposure or close contact, providing the vaccine is not thought to be a strategy to prevent the infection, and they do suggest waiting until the quarantine period is over for those persons. So you're really going to have to look at the history and the current status of the person getting each of these vaccines. And again, if it's a significant exposure, a close contact, they do suggest waiting until the quarantine period is over. But in nursing homes, residents who may have just been generally exposed because they are in the building with maybe another COVID positive person somewhere, those persons can be vaccinated. But if they have had a close exposure to them, not a close contact, but a relative exposure to someone, such as a staff person in your building, they should be quarantined as usual from others who have not been exposed. For exposed residents where COVID is not strongly suspected, you can go ahead and vaccinate those persons as well. And of course, any facility who's doing serial testing in general, there's no reason that those staff persons cannot be vaccinated. And of course, in terms of serial testing, that pretty much covers the entire state of Michigan. The CDC also notes that there are no contraindications for vaccinating someone who is suspected of COVID, unless you have a strong suspicion, who are simply waiting for test results. And again, they note here that testing to make a decision about whether to give a vaccine all in of itself is not recommended at all. In general, for the common underlying medical conditions, the vaccine is considered safe. During the clinical trials, they did provide the vaccine to persons with diabetes and heart disease, etc. So they feel that it is appropriate for use in those persons. However, they haven't really tested it on persons who are immunocompromised. They believe it is safe as long as there are no specific contraindications for a given person. There could be some issues, though, about how effective the vaccine might be, considering that these people have decreased immunity overall. So clinicians are asked to consider this and perhaps consult with an infection control specialist if needed. Pregnant persons can be vaccinated if they're in a priority group, such as a healthcare worker. But again, studies are not finalized for that group, but they don't believe that there will be any problems with that. And with this guidance just put out by the CDC, there's a long list of counseling information, precautions. Generally, the precautions overall are pretty much limited to allergic reactions. And of course, there is also information in this guidance about how to report adverse events following the vaccination. So the next couple slides, we're certainly not going to go through all of that. They're really pretty much links to a lot of what I was just talking about, a lot of educational materials. Remember, though, that these are all Pfizer materials, and although that they do speak in general about a lot of the issues for both kinds of vaccines, a lot of it is specific only to the Pfizer pieces. We anticipate that we will be getting the Moderna information as soon as they're available following final approval, which is expected at any time. The next slide more reading if you have trouble sleeping at night. And this set includes more general pieces about what to expect post-administration of the vaccine and a lot of information for consumers. So, questions about vaccines?
Okay, thank you, Deanna. Before we get to any questions, LeadingAge Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos up on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. All right, so we do have a few questions here. I know that you said you will discuss mandation of the vaccine for staff next week, but are you alluding to that it will be required that staff are mandated to receive the vaccine? We already have staff saying they will quit if mandated.
There is no state, federal, CDC requirement at all that vaccines are going to be mandated, and we do not anticipate that in any way. What next week is about is really some of the legal and just general issues that would be associated with any staff mandated policies that you might consider. We do identify that these vaccines have been created under an emergency use approval, and we think that that could be problematic going forward. And it's really the legal issues around facilities mandating the vaccine that is part of the discussion for next week.
My Walgreens rep said that we are getting Pfizer. The rep also said CDC has not set up the portal for the pharmacy tracking. How much are Walgreens and CVS getting directly?
I'm sorry, Blake, I didn't get all of that. Can you please repeat it?
Yep. My Walgreens rep said that we are getting Pfizer. The rep also said that the CDC has not set up the portal for the pharmacy tracking. How much are Walgreens and CVS getting directly?
How much vaccine are they getting directly? How much?
That would be my assumption.
Right. We do not know that. We are not aware of that at all. If that information is out there, we have not been able to find it.
This next one says, how many staff and residents are estimated in Michigan? Again, I'm assuming it's something to do with vaccination.
And I have not, I've not tried to calculate that. I do know that because the vaccines are coming in slow increments, that they will continue to vaccinate as long as they have access to the vaccines and in the order of priority that they've identified. In terms of overall volume, I don't know.
We have learned that vaccines that are authorized for emergency use cannot be mandated. I can email the FDA verbiage on this to you.
Okay, and I think that that's part of the discussion on Wednesday.
Holland Home, Atrio Home Health, Mercy Health Infusion Pharmacy, and Life EMS are ready to provide the monoclonal antibody infusions next week.
Okay, wow, good, great.
For those doing serial testing, will the vaccine make people test positive?
No. There is no indication of that in any way. And in fact, if you get a positive test after being vaccinated, you need to be considered as infected.
Okay. Deanna, can you repeat what you were saying about quarantine for non-close exposures? We have only been quarantining for exposures that meet close contact of less than 6 feet for more than 15 minutes in a 24-hour period. Did you say otherwise?
No, not at all. I was really just repeating what the what was stated in the information that came out. This is not a change at all to the way you're currently quarantining.
Is there a link to the CDC list of LTC providers assigned to particular pharmacies?
We don't have a link for it. We do know a lot of people have had it, and I thought we sent it out, but we do have that list, and we can send it out with the PowerPoint after this.
If we completed a partnership with Walgreens, are we locked into the partnership, or can we go forward with vaccinating with our own supply?
I would suggest you talk to your pharmacy provider about that. I don't know where you're getting your own supply, but you must be associated with a hospital or somehow with the health department. But I don't think that you have to. I would discuss it with your pharmacy. I do know that if the CDC list says that you have Walgreens, you have to stay with Walgreens. You can't move to CVS. That's the only piece that I am sure of.
We had heard HUD 202s were going to be included in 1A, yet we keep hearing no IL. Do we have any info or update on this?
Well, the HUD 202 information has always come from the federal level. We've really not heard how they're going to include that in Michigan. So that's a good piece for us to talk to the state about. I think we've had lots of conversations with the state, but I don't think the 202s have been included. So we'll put that on our list.
CVS has provided us with the Pfizer fact sheets for residents and staff. It specifically states accepting the vaccine is voluntary.
Right.
The person that asked the question and said they have a Walgreens rep, can you share their contact info, please?
And we can try and send that out, Blake, after if they send it in the chat box.
Okay. All right. Looks like that was the last question, so we can go ahead and move on.
Okay. Well, we wanted to spend just a few minutes this morning talking about MIOSHA. We heard from just a few providers who have had an on-site visit from MIOSHA recently, and we thought this could be a good time to review the MIOSHA emergency rules. And these are really high-level rules, but there's a couple pieces we want to make sure everyone's aware of. We did reach out to members to see if anyone has had a visit that they'd like to talk about, but we really didn't get any positive response to that. So we're just going to review these at high level and talk about the two major issues that seem to come up that we're aware of from a very small number of people. So these rules were put out in October, and they're effective only for 6 months, at least at this point. They could be extended with the pandemic if needed. MIOSHA in general requires that employers have a plan and activities to control, prevent, mitigate the spread. And remember, when MIOSHA is talking here, they're talking about all types of employers. At the time they issued these rules, they were saying that they had about 3,800 complaints from employees about hazards. And again, these complaints were not necessarily related to any one industry. So employers are expected to categorize each job and each procedure into risk categories. You will see through the 4 categories here that most of our workforce, our direct care people, will fall into high exposure level categories. Administrative or office personnel who are really not moving through the buildings much, they will fall into the lower exposure categories. So each employer has to have a written response plan, and that plan has to be consistent with guidance from both CDC and OSHA. I think every member knows this at this point. The plan has to include how employee exposures will be addressed through several types of activities, and this plan must be made available to all employees. The infection prevention precautions are not really different from other SNF, at least, regulatory requirements. But there's a definite focus on ensuring that staff, even non-care staff, are not sharing equipment and that frequently touched surfaces are disinfected. So one of the major focuses that we're hearing coming out of these MIOSHA visits is on disinfection processes. And in reality, this is not really just a focus for MIOSHA, but it has been a major issue for nursing home surveys as well. They are looking closely to determine whether or not you're using the right product in the right strength, applying it appropriately, and especially for the right amount of time. You will actually time staff providing these disinfection activities and making sure that whatever product you're using is actually in contact with the surface for the right amount of time. And of course, if any protective equipment is needed to protect the employee. And of course, facilities have to have a policy that identifies which staff can work remotely. For this next piece, there really isn't anything new or critical here. All of our member providers will know that they have to screen everyone. And although the CDC does have a crisis strategy for staffing where COVID positive persons can work in dedicated units, neither MIOSHA or MDHHS currently allow this. So anyone still suspected or actually positive must be quarantined at home or working remotely. The notification requirements are not different than those that we're already working under. Surveillance, again, not much different here from what we're all currently doing. You do have to have one or more designated safety coordinators on at all times. So you have to have someone on each shift identified as a safety coordinator. So for residential settings, that really does mean 24 hours a day. Educational materials, safety precautions, etc. must be posted. Social distancing is required. All of that is pretty standard. Face coverings and shields are required in alignment with all the other CDC expectations as well. So the other area of focus for these visits is that you must provide a respirator if there is a high exposure risk, and you have to follow all the current CDC guidance about that. The MIOSHA guidance says that respirators must be fitted, used consistently, inspected, maintained, etc., on an ongoing basis. We do know that in at least one site visit that was to, I think, an AFC, there was a huge focus on ensuring that N95s are being used. We're not sure, and this is one of the reasons why we kind of reached out to members to see if they were getting visits, if they were reviewing fit testing. We did know from our survey poll from about 2 weeks ago that most members are not fit testing for N95s. So if anyone does have any MIOSHA experience about that, we would love to hear from them. You can shoot us an email at our Safe and Calm address. They do state that facilities with known or suspected cases must use N95s, goggles or face shield, gown. And for some reason, they never include gloves, but we all know the gloving is required. A couple other reminders. When we went through the new CDC algorithm for antigen testing on Wednesday, the CDC documents actually talk about the 14-day quarantine period for persons, staff who have some close contacts. And they reference that 14-day quarantine period, even though there had been some CDC updates to that recommendation that MDHHS did concur with. We're on the wrong slide, Blake. Thank you. Okay. So, as I said before, the new algorithm talks about that 14-day quarantine period. Even though there are options to move it to 10 or 7 days, the department has allowed a reduction of that quarantine period to 10 days if the following two conditions exist. And we've talked about this. However, these are just options. The standard quarantine period for these kinds of exposures is still 14 days. So I wanted to make sure that no one was confused by the fact that they're using that 14-day number in those algorithms. We got a couple members who asked us questions about this. So using a less than 14-day quarantine for close contacts is completely an option, and 14 days is still considered standard. We received notice this week that HHS is sending another tranche of funding to nursing homes. They feel it's needed to better cover the losses and expenses. Overall, in general, the funds are delivering money to cover 88% of reported losses. And if a provider is not at that level, they will be sending some additional funds to those providers. This is all still CARES Act funds, and it's subject to all the same rules as the original monies. Payments for this additional set of money that they're providing are expected to start this week and last through January. Again, all the same rules apply. You must attest to the receipt. You must attest to all the terms and conditions, and reporting requirements are the same for other phase 3 payments. Apparently, according to LeadingAge, there's still some leftover funding from the CARES Act dollars, and this should help providers with additional expenses that may be occurred through the end of 2020. A couple other new notices from LeadingAge. They have issued a couple new tools and resources, a training series for a different series, but for both assisted living and senior housing communities about developing an overall pandemic emergency response. We specifically suggest that assisted living, AFCs, etc., who don't have a lot of experience with these emergency response protocols, review these, they're not really guidelines, they're just best practices. So these two new courses are available through Johns Hopkins working with LeadingAge. Yesterday, we did receive some updates about care and recovery centers. Before we get to those, I just wanted to make sure that everybody was aware of the current list of approved facilities, and they're here for your use and review. So, CRC update. Because the department's having a hard time ensuring that care and recovery centers actually adequately cover the entire state, they have decided to provide additional financial incentives for 4 of the regions in the state. Overall, the same basic criteria holds for any CRC. You still have to be a 3-star facility. You can't be under a denial of payment situation, not a red hand facility, and you must have a trained infection control champion. All of those criteria are the same. So the incentives actually have to do with additional monies. All of the incentives really are about providing an additional one-time payment to CRCs who are situated in any of these listed counties. So in other words, unless you're in one of these counties, you are not eligible to receive these additional funds. but these additional funds are substantial. You can see that the amounts range from an additional $60,000 one-time upfront payment, and that's in addition to the payment that was listed at the top here. So a facility with 10 to 24 beds who gets a $40,000 preparedness stipend, they will get an additional $60,000 on top of that for just applying and meeting the requirements, of course, for a CRC. And of course, you can't just apply and be a CRC and not take patients either. That's a huge issue. And in order to get this additional amount of upfront money, you have to be in one of the counties listed in Region 1, 3, 5, or 6. So that concludes our content for today. We can see if there's any final questions.
All right, thank you, Deanna. I will just hop right into the questions we have. This one is more of a comment, I guess I would say. Oakland County has come out to say we must continue to use 14 days in this county.
Oh, okay.
Based on the MIOSHA guidance, our skilled nursing facility is requiring remote work for all office staff, including billing, MDS, and even admissions and social services to some extent. Having these staff work from home is not ideal. When in the office, we have staff alternating who is in the office at the same time. Do you agree on our interpretation of the guidance requiring remote work for 6 full months? Are we expected to do this until at least April?
So I've not heard from any members who've had a MIOSHA site visit how they're actually interpreting this. They do include the statement in their guidance that anyone who can effectively work remotely should do so. So I would just make sure that your policies identify how the effectiveness issues. And it doesn't have any rules in this guidance that says this person should always be able to work at home or this person should never be able to work at home. I think that that's up to the facilities. And considering we haven't heard anything about that, I would think that what you're saying here is certainly appropriate.
Okay. As of right now, that is actually looking like the last question. So if you do think of anything after the webinar has concluded, feel free to shoot an email over to Dalton, Deanna, or Safe and Calm at leadingagemi.org, and we will make sure to get that answered for you. So at this time, we would like to thank both Deanna and Dalton, and we would also like to thank the 90 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that our next webinar, we will be holding it December 23rd at the same time as always, 10 a.m. Eastern Standard Time this upcoming Wednesday. And then we will not be hosting our webinar next Friday as it is Christmas. So I hope everyone has a great remainder of their Friday, has a nice weekend, and enjoys your holidays. Thank you.
Thank you, everyone.
Have a good weekend.